Okay, so welcome back to the Compassionate Cultures podcast. I'm Rebecca Hemmings, your host, and I've got a bit of an introduction today, so you've got to bear with me. Right, here we go. So, my guest today is Professor Partha Kar, who has told me I can call him Partha, a name many will recognize as one of the most influential voices in UK healthcare. So, he's a consultant in diabetes, endocrinology, I knew I was going to get that word wrong, endocrinology at Portsmouth Hospitals, NHS Trust, type 1 diabetes and technology lead at NHS England, and co-lead for the National GIRFT program for diabetes care. Now, you'll tell me if I said that wrong. His pioneering work has helped position the NHS as a world leader in diabetes technology and has improved outcomes for thousands of patients. And I'm sure my grandmother is one of those patients. But Professor Carr's impact goes much further than clinical innovation. He's used his platform to speak honestly about racism, privilege, and inequality within the NHS, helping to shape policies such as the Medical Workforce Race Equality Standard Action Plan and working with the General Medical Council to reduce racial disparities in referrals. So, as an international medical graduate from Kolkata, he is also an advocate for doctors and nurses from overseas and a role model for what compassionate, courageous leadership can look like in practice. So, can I ask you all to welcome, if you're all in the room, please welcome Professor Partha Kar. Thank you so much for joining me.
Oh, it's an absolute pleasure. Thank you for inviting.
Yeah, and so the reason I've asked you to come on is because I saw you give a wonderful motivational speech at the National BAME Health and Care Awards a few weeks ago in London. I was so taken by that. And so I know we haven't got you for long, so I'm going to jump straight in with our questions. And a lot of it is connected to that. So let's go back a bit. So you were born and educated in Calcutta, and since you've become one of the most influential figures in UK healthcare, so can I ask you what first inspired you to pursue medicine, and how has your early life and cultural background shaped your values and approach to leadership today?
Yeah, so I've had a very interesting mixed sort of background. So I was actually born in UK, and then I went back. I was when I was about 4 years old. So my mum and dad were from that generation. Doctors would come across, and I went back with them in the 70s. And when I went back, obviously I was in Calcutta, which is well, the country or the state is a very Hindu-dominated country, state. But I used to go to school in a very Muslim-dominated population, but a Catholic school. So it was
Oh,
an
wow. Yeah.
incredible sort of potpourri of all sorts of religious beliefs. And we were in a very different time. People didn't discriminate against each other based on who you prayed to. So I was brought up on, the prayer to the Lord and the Bible, but at the same time having the cultural mix of my own and the whole, everything around it. So did my medical schooling there, and a lot of the influence, obviously, for me going to medicine was my parents. And obviously, we come from a very traditional sort of Asian background, whereby the expectation is that you follow in the footsteps. That's changed nowadays, which is good because my children do something completely different. But and that sort of opened the door up to me then coming here to the UK in '99. So that's nearly
Yeah.
26 years ago now. So yeah, it's been a upbringing that I had of different colleges, different mix. I went to college over there. We had a huge population of people who came from a rural background, lots of deprivation, etc. So you start to understand a lot of things. So I suspect a lot of that has helped along the journey of trying to get to know other cultures and people and religions and stuff like that.
Yeah, and I think I can relate to it in ways. And I grew up in a very multicultural city or part of Birmingham, Aston, and I think it's quite an advantage
Hmm.
because you learn so much about being with people from different cultures. All right, I'm going to move you on now because you've led very transformative national initiatives like the Type 1 Diabetes Technology Program.
Mhm.
So, what do you think enabled you to create genuine change in such a complex system like the NHS? And was there a turning point that gave you the confidence to push for national reform?
I think I've always believed in two or three things. I think. for me, if you take a step back, diabetes is a very chronic disease. And I've always believed that if you give people who are living with a chronic disease all the time more tools to look after themselves, they will do better. Because in spite
Yeah.
of the best intention we have as healthcare professionals, we can't see everybody all the time because we just don't have the time. So the more tools you, and that sort of drove the sort of ethos. And then, of course, you start to understand the politics of it all, of trying to get technology through the approval process. I would say that, the success probably I would put it down to a lot of the community of type 1 diabetes. So I've been very open of engaging with them, trying to understand them, trying to work with them. So that's been, and I've got a little bit of blessed with, I would say, a bit of the gift of the gab. So I always can sit down and talk about influencing people. But I would probably say that the leadership thing that I bring, one of the three big things I always talk about, one is visibility. And I think that's a problem in the NHS. Not many leaders are visible, which is a
Yeah.
problem, right? They're
Yeah.
behind meetings and behind walls and behind an email. And you're going like, come on, guys,
Yeah.
at least own up to what you're doing. So I think that visibility has been very important and being honest with the people with type 1 diabetes. Hey, listen, it's not going to happen overnight. Give me time. I'm working through it.
Yeah.
So just as an aside, right now we're doing the artificial pancreas, for want of a better word. It's very clear. I said, look, I want to do children first. I want to do women trying for pregnancy first, and then we'll get to the others. Now that might cause unhappiness, but at least people are appreciative you being honest. So that's
Yeah.
visibility. The second one is being very clear about your plan.
Yeah.
And you're saying to people, that's my trajectory. This is my pathway. And the final one, which I've learned, I think it would be slightly naive to say I've learned that from day one as a leader, has been very much about surround yourself with people who know more than you a little bit. So you have, so for example, in my team, I've got some amazing people who do data. I mean,
Yeah.
amazing, right? I would just not be able to touch that. And if I tried to do that work, it would be really bad. So having those people, then I've got somebody who's brilliant at delivery. I mean, she's a manager. I will, if I go to her, like, do you know what? I need this happen. And she'll go like, don't worry about it. And we'll have, so I think that's been sort of, I would say, the three driving things of success. It's taken time, but I think if you recognize your own shortcomings, I know what I'm good at, and I've
Yeah.
learned what I'm not good at. You just need to find the other people who are good at what you're not good at, and then it
Yeah.
works well.
I love the clarity in what you're saying because
Mm,
it's quite simple, certainly on the surface
mm,
anyway. But
mm,
what you've mentioned visibility. But I mean, I don't know if honesty is a fourth one,
mm.
or maybe honesty comes with the visibility. But being seen and
Yeah,
being open with people, having a very clear plan, and then surrounding yourself with people that know more than you. I
yeah,
think those are lots of those are skills that are applicable to leaders regardless of whatever area they're in, and particularly when it comes to talking to marginalized people,
yeah.
those that certainly actually all of them, but certainly the
Mm,
first two are key. You
yeah.
need to be seen. You need to be seen to be listening to people, and you've got to have a clear plan and be realistic and manage
Mm,
those
mm.
expectations.
Yeah, yeah.
Yeah. Okay, so in your keynote speech at the National BAME Health and Care Awards, you spoke very frankly about the racism that exists in the
Mm,
NHS,
mm,
both on an interpersonal and
mm.
institutional level.
Mhm.
So, would you mind sharing one or two moments that were particularly defining for you in understanding how racism operates in the system?
Yeah, I mean, I think I always say this, and I've heard this from other people who have said it, that, people talk about, oh my God, they had a bit of unconscious bias. I think we really need to get past this concept a little bit because it's 2025, right? Come on, unconscious bias shouldn't become a corporate term to hide your racism behind. Okay, don't fall back behind that and say, oh, I just didn't know. Come on, you know, right? You know what you should and shouldn't say and shouldn't do. So I
Mm.
think personal examples are, I would give you one example when I was in training, and I obviously started my training in the Midlands. So I was in Worcester, Kidderminster, etc. And I then went down to the South Coast. And I remember a very senior clinician, when I was looking for my training number, coming up to me and saying, well, people of your type will not get any jobs here. You probably need to go back to the Midlands. And it's very direct, very open. And I still
Can
remember,
I ask, was he being mean or was he just being for himself, being honest?
no, I think they were honestly being just matter of fact. I think the fact that people could come out with that quite comfortably. So that's one example. And to be honest, that to me said, to me, I turned around and said, you know what? I'm going to get a job here. I am going to get a job here, which is what I
Mhm.
ended up doing. So, um, and the second gigs up, and it's not just confined to the fact that I was a trainee in those days. As I've grown more senior, it's always been when I was doing the work around adoption of technology. I've had the chief exec of a certain ICS having a meeting and saying, "Well, people of your type don't understand our culture." And I said, "Explain that one
Mm,
to me.
yeah.
What do you mean?" And they said,
Mm,
"Well, you're very robust with your challenges." And I said, "Well, I'm not quite sure on what analogy that even works, right? I come from India. If anything, we are very polite. You come from Britain, who took over half of the world. So I don't think that analogy. So I think you need to have that tongue-in-cheek conversation but people can say that. So I faced that, and obviously when I was doing the talk, I gave the example of what I faced in NHS England, a throwaway comment, and I've always stood up against it. And as I was saying, what I think a lot of us need to do is by luck, by default, by whatever be the thing, if you get to a position of privilege, your job has to be to give that fire cover to somebody else who will not have the privilege that some of us carry. So,
yeah.
unfortunately, I don't think it happens enough in the
Yeah.
NHS, if I'm very honest. I think you'd see
Yeah.
people of color not quite doing the job that they should be doing, sadly. But that's part of the sort of politics, I suspect, as well.
Can you just break? Because I felt like you really broke this down at
Mm.
the awards, and I really, for those people that weren't there, I really want
Mm.
them to understand what you mean by, passing on that privilege, or to, break down what you just said, because I think that's really key.
So I think if you take my example, so I am steeped in privilege, right? I'm a consultant. I've got some pedigree. I'm a consultant for 15, 20 years. I've got a professor degree. I've got publications. I've got this, that, everything, right? And I work in national roles. I lead diabetes. So you can't go higher than what I do in my specialty field. This is it. Um, so the option I have is to ignore when somebody raises to me an issue of racism they face, or an issue, or I'm sitting in a meeting and somebody says, just let it pass. But the second option is to use your privilege and say, I don't think that's right. And I think this is very, very important, and we should do more of it. And it's not just racism, it's sexism, it's racism, it's
Yes.
homophobia, it's any protected characteristic. All it needs. So I always talk about allyship, and allyship in the NHS has mostly become very performative.
Mhm.
It's very much about, oh, here are some, posters I did, and I stood by you, and I took some pictures, and I did a selfie, or I did a hashtag campaign. No, it's
Yeah.
about the quieter moments in meetings and stuff, and you just saying that, or when somebody reaches out to you, not always to give them a solution, but sometimes they're just looking for somebody to listen to them.
Absolutely.
You
Absolutely.
may not be able to help, but they're
Yeah.
just reaching out to you as somebody who's senior. Takes you what, 5, 10 minutes of your life to
Yeah.
listen and say that, I totally empathize. So I think that's the privilege. And there's plenty of people who, if you take the BAME Awards, there's so many people in the room. And I think if we all collectively did that, we could
Yeah.
tackle lots of the discrimination that we see from day to day.
I know you're enjoying the episode, but I've just got to tell you this. If you're wanting your organization to transform with regards to diversity and inclusion, you need to check out our Crafting Compassionate Cultures online learning hub. It includes our 4 CPD accredited online courses, including one around anti-racism, microaggressions, sexual harassment, DEI, and more to come. It includes team leader packs so you can have discussions with team members about the learning, our HR integration toolkit so you know exactly how to roll out this program, and it's got email templates and more, certificates of completion, monthly learning reports, a monthly expert-led Q&A, and bite-sized videos, and so much more. Want to find out more and to trial it for 1 day free of charge, no questions asked? Visit our website www.strawberrywords.co.uk. That's strawberrywords.co.uk. Now back to your episode. And I think it's also important to know that you don't have to be racially marginalized in order to do that.
No.
I think that's really important because obviously you spoke about people that were there on the day who
Mm.
were from that background, but absolutely.
Yeah.
So, and yeah, I think it's really powerful when it actually
But
comes from someone who's
let
not
me
from
give
that
you one
background.
example.
Mm,
And I'm going to give the example of sexism, not racism in this context. When a group of men and women go out and a man makes a crass comment, let's say about their dress, about their hairstyle, or whatever. you do if it being a man is not about allyship is not about making an absolute song and dance and a scene about it. Allyship is about quietly saying that I don't think that's right. And that's all
Yeah.
you need.
Yeah.
Because a woman actually appreciates anybody being an ally and just saying that what she's going to say, but the woman say they'll go, oh, you're just being dramatic. It was just a comment. It's not. It clearly affected the person. And as a friend, all you can do as an ally, you go like, I don't think that's right.
Yeah.
You
It's
know?
living in integrity.
Absolutely. So I
Yeah.
think this is what I say to people. Your allyship shouldn't be performative. The allyship should be in quieter moments when nobody else is watching, right?
Yeah.
That's when it is most important.
Yeah. Absolutely. Thank
Hmm.
you. Um, you helped publish the first action plan to tackle racism within the medical workforce,
Mhm.
and you work with the General Medical Council to reduce referral
Yeah.
inequalities based on ethnicity.
Yeah.
What tangible changes are you seeing from this work? Because it's often a question we get asked about our work. What changes are being made? What differences, have
Yeah.
happened? And also, what still needs to happen to
Yeah.
create genuine equity, particularly for healthcare professionals from a racially marginalized background?
Okay. So I think the first things first that needs to happen. Let me tell you about what I think needs to happen, then I'll tell you some of the progress. I think the first thing that needs to happen is clear disaggregation of data. Non-white is not one homogeneous mass. That's just nonsense,
Mm,
right? We need to stop this
mm,
because in doing so, people will show improvement of data, but actually none in the black community because it's mostly gone towards a lot of the people from the South Asian background, right?
yeah,
That's not improvement.
yeah,
So if you really want to do it properly, you need to disaggregate data. So we, for example, know if you look at the medical data, if you're black, your chances of getting into medical school, passing your medical exams, getting a training job, getting a consultant job is lesser than anybody else. Now, you pack it in with everybody else non-white, the gap suddenly becomes much more tighter, and you go like, well, it looks all right.
yeah,
But for the black person, they're going like, it's still not all right, but nobody's
yeah,
talking about it. So I
yeah,
think data disaggregation and being very open and tackling it is very important,
yeah,
right? So I think that's the first thing that needs to happen. I think it's been an interesting journey, I would say, doing the race equality work because I think it's fair to say, due to the politics and or maybe individuals, NHS England lost a lot of interest in tackling it at the end of in 2023. Suddenly, it was no longer a focus. They were like, "Oh, we'll do everything together." I think this is the problem with when you say EDI or DEI because it comes under criticism and sometimes rightly because it's like an ethereal blob which is not tackling anything
yeah,
because tackling sexism and racism or homophobia are not the same thing.
yeah, absolutely.
That's just
Yeah,
silly to even
yeah,
comprehend that. But when you do things like that, which is what happened with NHS England 23, nothing progressed, and everybody just gets more frustrated. To your point, what's happening? What's
yeah,
changing?
yeah,
So discernible things to target are very important, so you can clearly show outcomes of success or failure, and that's why we picked two. So if you look at our five markers we picked, there are two things which have improved. One is representation in all the medical royal colleges and councils have certainly improved, which is very good.
yeah,
And secondly, I think the General Medical Council referrals based on the color of your skin has tightened. And I think that's really, really good. Okay. Because we have been going out and challenging people who do the referrals. Now, I don't think the same has happened in, for example, the nursing or the pharmacist or other backgrounds, and it needs to
yeah,
because somebody needs to explain why for example, why is a black nurse more going to be at a band 5 than anybody else? What is it? Are we just saying that they are lesser qualified? Is this
yeah,
what we're saying, or are we just not giving them opportunities? Similarly to, I would say, referrals. Why are they getting more referred, right? And it translates back into health inequalities. And it's very well now shown your black mothers, the care they go for pregnancy. We keep on talking about, and I have this conversation with many people who lead this work, is that you have to challenge the racism in the staff.
yeah. I want to jump in. I want to ask, like, do you, because I know just from the work that we
Mm.
do that there's a lot of resistance to talking
Yep.
about racism.
Yep.
And so, how is that dealt with, knowing that this is a problem that needs to be dealt with, but knowing there's this big barrier because people are really scared of talking about racism because they fear being called racist or it's people don't know enough. How do you deal with that bit?
So I do it in a very different way, and I'll tell you what we did with technology, right? outcomes. So when we had technology, we saw that the black child had half the chance of a white child. Half. It wasn't in decimal points, but half. Like 20%, 10. And I remember sitting with all the staff, all the pediatricians, and said, looked, showed them the data and said, what do you think? And this particular pediatrician put his or her hand up and said, well, we just find it very offensive. I said, why do you find it offensive? So we find it offensive because it feels like you're calling the staff racist. I said, no, I'm not yet. But I would like to know because there are three options in front of you when you look at this data. Option one, do you know what? This is wrong. I'm going to sort it. Option two, this is wrong. I'm going to sort it, but I tried and I failed. Option three, it's okay. Now, if you choose option three, the term to describe you is a racist because you have said a black child should have a less than a white child. That makes no sense. Diabetes is diabetes in the children. On the other hand, I have got a lot of time for group one and two, even the ones who fail, because I keep on
Yeah,
saying to people, it's important to try and fail. So I tell everybody what failed, but don't do anything. So my way of tackling this is that if you're saying that you're not a racist, it's nothing to do with the staff, close the gap for me.
I absolutely love that.
So right now, in 25, the achievement of uptake in white is 94%, in black is 93%.
Wow.
Exactly. It's doable. I think you just need to sit down and go like,
Wow.
show me a better result. I'm
Yeah.
basically saying the hypothesis I'm
Yes.
saying is that it could be due to staff being racist. If that hurts you, turn it around.
Oh, I just love all that clarity because because it cuts out all the
Yeah,
noise
cut
and
all
it's
the noise.
basically saying, look, this is the problem.
Yeah,
One and two, either you think it's wrong or you
yeah.
think it's wrong and sorry, you think it's wrong, I'm going to do something about it. I
Hmm.
think it's wrong, I did something about it, failed, or I'm not going to do something. That's it.
That's it.
Wow. I love that.
And I think you also use the concept, what I call the null hypothesis in research. You go like, okay, I agree with you. This has nothing to do with staff. Staff are all angels. They're brilliant people. Fair enough. Prove me wrong. Prove me wrong. And people then go out of the way to prove you wrong because I think I have always said this. We are all part of society, right? All of us are human beings, part of society. We all got our foibles. We all got our prejudices. I've got some, I'm sure I
We
do,
all
and I've
do. We
learned
all
along the
do.
way. So, for example,
Yeah.
the whole concept of anti-blackness, I've learned more as I've grown older, right? And I've had some really good friends and colleagues from the black community have educated me about it. I'm going, you know what? That's probably right. Those are comments I've heard, and I've never quite realized the impact of that. And that comes more from the South Asian community, not necessarily the white community, right? So I think when you are on that sort of journey, you need to be very clear with people what you're trying to achieve. And there should not be any hesitation in saying that racism, and I think the other thing that I find is very good to engage people is saying, why are you assuming racism is just a white and non-white thing? I never said that. I never said it's a white and non-white
Good
thing.
question. Yeah.
It could be a South Asian and a
Yeah.
black community thing. It could be a black against the. It could be all ways around.
Yeah. Yeah.
You are just making the jump of assumption that I've
Yes.
said is white versus non-white. And the
Oh,
thing
that's
I
so good.
always, yeah, and I think that the final thing I always say on this is that we have to admit we are human beings with our foibles. Nobody goes to work, puts on their NHS badge, figuratively, and suddenly becomes some sort of angel without bias. That you will carry your bias into work. That's how it works. If you believe women are inferior to men, there is absolutely no way you're going to treat a woman at par. That is just not going to happen. You can tell me any lies you want, but if that's your fundamental belief, that's your fundamental belief, right? So, and if you believe a black child is uh, less worth saving, treating than a white child, or is a lesser being, you will not give them the full attention of your medical care that you would give to a white child.
Yeah.
So it sounds harsh, but it's fact. And I think
And
you
yeah.
need to be honest about it.
Yeah. Oh, so good. I'm very conscious of the time, so I'm going to move on to my last question, but I'm
Mm,
really holding on to everything that you just
mm.
said. Um, so I'm really thinking about this next generation of medical graduates
Yeah.
and leaders who are from those racially marginalized backgrounds entering the NHS. If you could give them one piece of advice based on your own experience, what would you say to them?
Find allies, right allies. That doesn't mean people of your own kin or color. That's not always the case, right? I have had some magnificent supporters and people who come from a Caucasian and white background. Amazing friends, amazing supporters. Find your kin, is what I would say in that sense, which is not dependent on the color of your community. That's one. Two is, I don't think, and I say this, don't forget the Northern Star, what you're trying to do, right? And I think it's very important is that, and if you're focused on something, this is what I want to do, then don't be afraid of speaking up. You're not saying anything which is fundamentally wrong. It's about the manner you deliver it, which is very important. And thirdly, I go back again to privilege. You will get to privilege, pass on your privilege and the benefit of the privilege to another person. Right? I think that's really, really important from people who are coming from those communities. You step up and you create and I'll give you one example of that. So when I started doing the work that I was doing, I remember the then chief exec, Simon Stevens. And I said, Simon, you know me, I'm a bit of a maverick type character. I'm going to might rub people off the wrong way. And I remember he said to me, but you're doing it for the right reason, aren't you? I said, yeah. He said, yeah, you want type 1 diabetes outcomes to be better. I said, yeah. I said, okay, as long as you keep it polite in the sense of you're not insulting anybody, being disrespectful,
Yeah.
I will back you all the
Oof,
time. And he did.
love
So
it.
that's where we are.
Yeah. So many insights. Thank you so much. I've got to give you, your props, Professor Partha Kar. Thank you so much for your insights, from your leadership advice to always bringing it back to, what you can do personally. And it is about that personal responsibility, whether it's using your position when you're in that position of leadership, or whether it's just, you really being honest about if you want to really help, or you're actually just okay with the status quo. All of that is such essential information. So thank you from the bottom of my heart. It's been a pleasure.
Pleasure's all mine. Thank you.